Today I'll be talking about Transkambin fusion versus oblique lumbar interbody fusion and their effect on disc height, segmental lordosis and lumbar lordosis. Transkambin lumbar interbody fusion, which is also called the oblique lateral lumbar interbody fusion, and oblique lumbar interbody fusion anterior to psoas, work on the principle of indirect decompression. Both the techniques restore disc height, segmental and lumbar lordosis, and both the techniques can be done in a minimally invasive manner. The aim of my study was to compare the restoration of disc height, segmental lordosis and lumbar lordosis in OLIF and OLIF groups. It was a retrospective study. Patients with spinal canal stenosis with spinal instability, normal neurology and in whom OLIF or OLIF surgery was done were included in the study. The radiological parameters were measured on X-rays using the SurgiMap software. Appropriate statistical analysis was done. The lumbar lordosis and the segmental lordosis can be measured on the software itself, and the disc height is measured as the average of the anterior and the posterior disc heights. This is the demographic data. Both the groups have 50 spinal segments. The age and gender distribution is similar. Degenerative etiology was the most common and L4-5 was the most common level involved. The change in segmental lordosis and lumbar lordosis was significant in both the groups. However, the change was higher in the OLIF group as compared to the OLIF group. Similarly, the change in disc height was also significantly increased in both the groups. It was a 103% increase in the OLIF group as compared to an almost 60% increase in the OLIF group, and it was statistically significant. The increase in the segmental lordosis in the OLIF group can be attributed to the lordotic cage design and the anterior placement of the cage, which gives a long liver arm when compression is applied after posterior percutaneous fixation is done. As we can see in the OLIF group, the liver arm is short and the compression can give lordosis but less as compared to the OLIF group. So in conclusion, both techniques can effectively restore radiological parameters and the comparable clinical outcomes can be achieved. The limitations include a retrospective study and a small sample size, and other radiological parameters such as spinal canal cross-sectional area, foraminal cross-sectional area and the change in ligamentum flavum thickness were not taken into consideration. Thank you.